All right, good afternoon and welcome to our monthly community engagement webinar. My name is Deborah Volleson and I am joined today by Gary Herbst, Cahuilla Health's CEO. And it is always a pleasure to join you just to give you updates on what's going on at Cahuilla Health. And in our goal for transparency, we'll answer any question that you have. So feel free to chat it in and the team that's working behind the camera will get it to us. But today is Thursday, June 27th. We are halfway done with 2024, which is a little crazy. And it's also the celebration of the end of a fiscal year. And so
yeah, I was going to say, I don't know if anybody has this on their social calendar, but Saturday night is New Year's Eve. At least it is for Cahuilla Health and the state of California. Both of our fiscal years run July 1 to June 30th. So June 30th, which is Saturday, marks the end of fiscal year 24. And, excuse me, am I getting that wrong?
Yeah, no,
Sunday
you're right.
night. No, Sunday night.
Sunday night is.
June 30th. Sunday night would be New Year's Eve, not Saturday night. Although we don't really like to party on a school night, let's say in my house. Sunday, June 30th, the end of fiscal 24. And then first thing Monday morning, July 1st, we'll begin the new fiscal year that'll run until June 30, 2025.
Yeah, so we don't really party. It's kind of like you breathe a sigh of relief that, okay.
Yes, yeah.
And we look forward.
Yeah, we didn't sprint across the finish line. We kind of collapsed at it, but I know our folks in finance, they probably have a little bit of celebration.
So today, we've been really busy. There's a lot of things that you're going to cover at the end of the broadcast. It's been very busy. But today we're going to focus on a few of the questions that have been asked to us over the last few days. And we're going to talk about our mental health. Our mental health services, the mental health expansion, and we have some questions on that. We're going to ask a question about how the new resident physicians are supervised, and we just welcomed 50 new residents, which you're going to cover at the end as well. And then we're just going to talk about some things going on in the community, some updates with Cahuilla Health. And like I said, feel free to chat at us and we will answer your questions. Okay, so there was recently an article in the Visalia Times Delta about our mental health hospital expansion, which we received a grant to do. But I'm going to ask a few of the questions and then we'll go through them one by one. So the question was asked about the different ages that are going to be covered in this adolescent and child expansion. The difference in this facility and the crisis stabilization unit that's coming in downtown, and then what happens currently to children, because unless you have a child in that age group, you really don't understand the crisis.
Right.
And when we talk about it out in the community and community members share with us that they tried to get mental health services for their children and they're going out of the area, people who aren't in that really don't understand how that is impacting our community members who are trying to get those services. So let's start with the article. And the article talked about it being an adolescent and a child mental health facility. But what is considered an adolescent and what's considered a child? Because we've heard that it's going to talk about ages all the way up to 21. Then we've also heard it ends at 18. So can you kind of give us the definition of ages?
Yeah, and it really depends on the specific facility and the services that you're speaking about. So with respect to the child and adolescent crisis stabilization unit, which through a grant and working with the County of Tulare Health and Human Services Agency, we acquired the former Boy Scouts headquarters in northeast, I think it's northeast Visalia. And through that grant and working with the county, we will be converting that facility into a 12-bed child and adolescent crisis stabilization unit. So in many respects, it's like an emergency room or department for children and adolescents, but not those that have a medical condition. They have a mental health condition. They are suffering an acute crisis, mental health crisis. So right now, if you're a child or adolescent and you're having that mental health crisis, you go to our emergency department, which is a 73-bed facility that we're probably going to see 100,000 visits in it this year. We're setting literally a record, our 60-year record of the number of visits. We do have a 9-bed unit that we call Zone 4 that is specifically designed to care for patients that are suffering a mental health crisis. The rooms are designed to be fully ligature-free so that a patient can't harm themselves in the room. But we have a lot of children and adolescents that come to the emergency department right now because there is no crisis stabilization unit for them. So when that 12-bed unit opens, it will take children all the way up to 21 years old. So that's that facility. I know, so you're looking at me puzzled. So that one is all the way up to 21 years old. That's that emergency, crises. So what you're talking about, which was also funded by a very large grant that came from the Behavioral Health Initiative through the state of California, was to allow us to build a 22-bed addition to our existing inpatient psychiatric hospital. So we're one of the few hospitals still, certainly in the San Joaquin Valley, if not the state, that still operates an acute psychiatric hospital. So we have a 63-bed locked inpatient psychiatric hospital, currently only for adults. It's located on our west campus, really located on the corner of kind of Acres and Tulare Avenue. And so it's only for adults, but patients that are potentially a harm to themselves or a harm to others, this is a facility that they can stay in and receive the care of psychiatrists and psychologists. They can manage psychotropics to control or treat their particular issues. They can stay for a few days, they could stay for a few weeks, depending on their condition. Most often the patients that are there are not there voluntarily. A determination has been made that, again, for their safety or the safety of others, that they need to be treated there. This child and adolescent wing that will be built in the front part of the acute mental health center is both for children and adolescents. And so it will be, even though it's physically part of our existing inpatient psychiatric hospital, it will be very separated. It will have its own, exercise yard, its own dining, its own, there'll definitely be separation because we do not want to mix children and adolescents with adults. So I think people were kind of concerned that it was just going to be a larger facility and that we're combining children and adults together, and we're not. So it will have two phase or aspects to it. There will be the child part and there'll be the adolescent part. So the child section will be for children that are 12 years and younger. So that for that population. And then children between the age of 13 and 18 who are considered adolescents will be in the adolescent side of that 22-bed unit. So clear separation from adults, but even within the child and adolescent, definitely recognizing, to be younger than 12 versus a teenager that's 13 to 18, very different issues and things that they're dealing with. And so we want to be able to separate them as well. So those young people that are age 18 to 21, they go into the adult unit. So I think that was the puzzled look on your face, is that the crisis stabilization unit in North Visalia, which is again kind of that emergency department for acute crises, that's up to 21 years. all in the same facility, that 12-bed unit. But then and that's outpatient only, like the emergency department. Then this inpatient facility there'll be a section for children 12 years and younger. There'll be a section for adolescents age 13 to 18. And then those that are in that group 18 to 21 will be in the adult unit.
Yeah. So, and the reason why I made that face is, because I'm a mom, but to me, a 21-year-old in a crisis stabilization unit with, say, a 6 or a 7-year-old, they can vote, they can drive, they can drink. I kind of consider that more of an adult.
Yeah, I know, I understand that. But again, I'm confident that the staff, and there certainly will be security there, and so they will make every effort to, really separate age groups. Because, no, you're absolutely right. An 8 or a 10-year-old that is suffering a mental health crisis with a 20 or 21-year-old, very, very different. What we'd have, and we've met with the county several times, is an adult crisis stabilization unit. That's really the next step for our community to have. And I would imagine if we did have that, then we'd probably only take up to 18, kind of like what they're doing in the inpatient side. They'd only take up to 18 years old in the child and adolescent CSU, and then 18 or above in the adult. Unfortunately, there is no funding to make that adult CSU a reality. The county doesn't have the funding. The state doesn't have the funding. We as an organization, and this really came out of our community advisory committee. One of our community advisory committees that was very focused on services of the future. The number one priority among that community advisory committee in terms of what they felt was the most serious unmet need in our community was the availability of mental health services. So our board, our executive team has made a very strong commitment to increasing the availability of mental health services in our community. It's one of our 6 graduate medical education residencies programs in psychiatry. And most recently, just a few years ago, we launched a child and adolescent psychiatry fellowship program. So our psychiatrists, which is a 4-year program, generally after 2 years, if they want to go into child and adolescent psychiatry, they had to leave our community and likely not return. So now our own residents after their 2nd year go into our fellowship program, and virtually everyone that has graduated are staying here and wanting to practice. We have mental health services available in virtually every one of our rural health clinics. Lindsay, where Dr. Corey Jakes is located. Dr. Jakes is the program director over that psychiatry fellowship program, but we provide a tremendous amount of both adult and adolescent outpatient mental health services across our 5 different rural health clinics, so that's definitely a site of service. Certainly the emergency department. We hope to have that child and adolescent CSU open by next spring. It'll be a little while longer to open up that 22-bed inpatient unit, child and adolescent, at our mental health hospital. We also have the Quia Health Center for Mental Wellness. Yes. Thank you. Center for Mental Wellness over on Noble. I think it's like Encina and Noble. That's also one of our latest offerings. Again, really tailored to folks that need that outpatient mental health support, and which has been very difficult to access. And unfortunately, we all know that COVID has really exacerbated just the mental health of our community, of our society, and it's hit children and adolescents very, very hard. So this is definitely the right thing to do as a healthcare organization, and it's just very exciting to see a lot of these projects come to fruition.
Yeah. And so my mind is kind of whirring on this, and so I might be asking you questions that we need to get others to answer, but you may know this. So is it going to be up to an EMT to make that decision? So say they pick up a child.
Right.
Is an EMT going to make the decision as to whether or not that child goes to the ED or to the CSU?
Yeah, that's an excellent question, and I don't know the answer to that. I mean, generally, if an ambulance and an EMT is responding to a 911 call, or they have a child or an adolescent that's suffering an acute mental health crisis or episode, they're calling into our ED and speaking to our physicians that are manning the EMT ambulance phone.
Okay.
And so they'll be having a conversation. And so it may be that the determination is being made at that time by that physician in communication with the EMT. But I don't know if the EMT, certainly during COVID, there were times where EMTs were making decisions in the field, whether to bring the patient to the hospital or not.
Right.
But that was specifically related to COVID. So I don't think that they have that authority anymore to actually make a decision in the field whether they needed to come to the hospital or not. So, but it's a good question, and we can follow up on.
Yeah, and that is, we just finalized some of the contracts with the county. So the CSU, hopefully, the refurbishment and the remodel of that starts soon so that we can maybe open.
Yeah, we've had
facility.
delays, unfortunately, and
Yeah.
we're getting really anxious. But I think I talked to Kevin Morrison, who is the director of our facilities planning here at Kuya, very involved in that project. And I think he had told me that they were hoping by next spring.
Awesome. So another just logistical question. So when an employee, or not an employee, so when a patient comes into our ED that it's mental health related, does he ever go directly to the mental health hospital, or would they go first to the ED and then they're sent to the mental health hospital?
They would generally first go to the ED, where they're going to be assessed. We have mental health workers in the ED. We have a psychiatric liaison, which is actually a physician psychiatrist that is stationed in the ED supporting the emergency department, as well as potentially consulting on patients that are already admitted in upstairs. And so that determination, whether that patient needs to be transferred to the acute mental health hospital, is generally made in the ED. I don't believe, I've not heard of patients going straight from home to the mental health hospital.
Okay.
They generally always first go to the emergency department.
Okay.
And sometimes we don't have a bed.
Right.
It's unfortunate. It's a 63-bed hospital, and we generally run a census of around 50. And you say, well, why can't you fill all 63 beds? Well, unfortunately, the population that we're caring for is increasingly violent. And so we're having to do more isolation, and because many of the rooms are designed for 2 beds and 2 patients, but when we have to do isolation, then it doesn't allow us to use all the licensed beds. And right now we're doing a lot of construction in the mental health hospital. There's actually like 3 physical pods, and each of those pods has a nursing station. And unfortunately, however it was designed, the nursing stations are too open and too accessible to the patients. And so you have largely a female nursing workforce, and I'd say the majority of our patients tend to be male patients. And so there's not enough physical barrier there to keep our staff safe. And so we are remodeling all 3 of those areas to create a safer environment for our employees. But that's requiring that we shut down that wing. And so we've had to curb our inpatient census while that construction is taking place, which now means that we're boarding mental health patients in the emergency department for sometimes days on end. They might be in the ED 3, 4, 5 days, ideally in that zone 4, those 9 beds for mental health, but waiting before they can be transferred to our mental health hospital or potentially transferred out of the area to another mental health site.
So if a child is admitted to our mental health hospital, once this opens and a child is admitted, do parents lose their rights, their basic rights?
No, not
Okay.
at all. Not at all. I know there was a concern, did they become a ward of the state, or the answer is absolutely not. The parents are always still involved in their child's care. If the parents are unable or unwilling or not available, to care for their child and make decisions for them, then there is a legal process that you can go through to literally make them, I guess, a ward of the state. Kind of similar to when you might conserve an adult patient that does not have the ability to make decisions for themselves anymore and does not have family that are able or willing to care for their loved one. So, but definitely parents absolutely involved in the care of their child.
Okay, so you mentioned our Center for Mental Wellness. Do you know how many patients are a part of that?
I do. So we saw our first patient at that center back in September of 2022, which is hard to believe. I remember the grand opening and doesn't seems like yesterday, but so we finished that fiscal year. So in September 22, that would have been part of the fiscal year that ended June 30, 2023. So we saw 545 visits in that initial year. This last year, which again ends on Sunday, we are projecting that we are going to end just shy of 3,000 visits. And for next year, that will start on July 1, we are budgeting 4,500 visits in the coming fiscal year. So definitely getting busier and busier, which is a really good thing.
And those are licensed clinical social workers?
Yeah, they tend to be, LCSWs, marriage and family therapy. We do not have any psychiatrists that practice in that site, but they are all licensed mental health workers.
Okay, fabulous. So I am sure in the next year where you're going to have so much more information to give out about the CSU, the mental health expansion, because as you said, the services are more in demand and we're excited about being able to meet that need. It's really heartbreaking to think that kids are kept in the ED.
I know.
Because that's just, it's a place of trauma.
It is. I mean, obviously, we have a lot of sickness, medical sickness, illness, a lot of traumatic injuries. We do have trauma. Setting a record, there are days where we're seeing 300 patients, and some of them very seriously ill. You unfortunately, a number of people probably watching this have been patients of our emergency department, and it's quite a diverse population that we care for. And to be a young child, that is really going through some serious mental health challenges, it's not a very soothing, warming, environment.
Right.
Yeah.
Okay, so more to come on that. So, Gary, you mentioned when we did the grand opening of the Center for Mental Wellness, you just felt like it was,
Yes,
and
right.
I was thinking in my head, I think that was sometime in 2023. So when you said 2022,
Yes.
Last night we celebrated an employee who had been with us for 39 years.
Yeah.
And I don't know if you caught her comment when she said, it's really a blink.
Oh, yeah.
When you look back over time and it's like, it's a blink. Time goes so fast. But we're going to talk about the residents here for a minute. We did a special welcoming for them on Monday night. And as they were coming in, and I know it's a sign of age, when you start going, oh my gosh, they're kids.
I know.
They're kids.
We've turned into our parents.
Yes,
haven't we?
yes, we have it.
Yeah.
I'm looking at all these doctors walking in and I'm like, okay, they're my kids' age. But we're going to talk a little bit about the residents, but do you want to start out by talking about them coming in and our welcome?
Yeah, sure. It was definitely Doogie Howser in real life. June obviously is a a very celebratory month. All the high school graduations and 8th grade graduations and graduations from kindergarten, and a lot of marriages, weddings occur in the month of June, very popular month. And so definitely a celebratory month. And it was so for us as well with respect to our graduate medical education program. So just a few weeks ago, mid-June, we out at the Wyndham Hotel off of Plaza, we had our annual graduate medical education graduation ceremony. So roughly 50 of our residents across our 6 different residency programs, and for the very first time, graduating 3 of those child and adolescent psychiatry fellows who graduated from their fellowship program as well. Had a wonderful time, all their family and friends in the audience, and but it was exciting to see them. They get all dressed up and everything, and but yeah, very young, and exciting to see that many are planning on staying in the Central Valley here and working locally. A number of them wanting to stay and work here at Cahuilla Health. So that was great. And then the next Monday morning, Dr. Lori Winston, who's our chief medical education officer and oversees the graduate medical education program, we welcomed 53 brand new residents and fellows to Cahuilla Health. So it was a great juxtaposition. You know, here the week before, we were celebrating the end of the residency programs. And these residents are here 3, 4, 5 years, depending on which residency they're in. And so they're leaving us. And then 1 week later, we're welcoming in the brand new interns that this is their first day starting their residency program. And to think that 3, 4, 5 years from now, we'll be celebrating their graduation. So kind of a surreal moment. But again, they're all dressed in suits and just, but they're youthful, no doubt about it. And then Deborah mentioned last Monday night, we had our 3rd annual new resident mixer at the Children's Museum, the Imagine You Museum. We had a great turnout. Deborah did a phenomenal job. She coordinated and planned the whole thing, as always. Brenda Isaac catered it, phenomenal food. But we had a really wonderful story told by Sam Logan, one of our community advisory committee members, who was one of the first individuals in our Host a Resident program, where, you know, these young kids coming out of medical school, many of them come into a foreign, you know, community, a city, that, and unfortunately under COVID, you know, they didn't even visit. All the interviews are now done virtually, whereas they used to come on site for their interview and going through that match process. So could you imagine, I think his resident that lived with him was from Florida or
like Nebraska.
Oh, Nebraska.
Like the Midwest,
yeah, he's
right?
from Nebraska. I don't think he'd ever been to Visalia. And Sam opened up his home for this new resident who lived with him and continues to live with him, even though he now graduated. He was one of our transitional year graduates, but he has what's called a gap year, where he's got a little bit of time. I understand he's going to teach at the local medical school, I think in Clovis, before he goes on to do his additional training. But both he and Sam just told a wonderful story, and certainly encourage any of you that are interested in hosting a resident or a fellow. It's a great, very generous gift for our residents, and sounds like it was every bit as rewarding for Sam as it was for the resident.
Yeah, when his resident leaves, he's probably going to be running out after him. Don't leave, don't leave. But the question came up, how are they supervised?
Sure. Yeah, so we have 6 residencies, family medicine, emergency medicine, general surgery, anesthesiology, psychiatry, and what's called transitional year, which is a 1-year kind of general education, an internship, and it's for physicians that want to go on to become radiologists or physiatrists or dermatologists. And so we have those 6 residency programs, and then we have the Child and Adolescent Psychiatry Fellowship Program. So each one of those programs has a program director. So Dr. Mario Martinez for family medicine, Dr. Sean Oldroyd for emergency medicine, Dr. Sebastiano Casaro for general surgery, Dr. Emily Smith for anesthesiology, Dr. Mandeep Baga for psychiatry, Michael Stanley for transitional year, and Corey Jakes for the Child and Adolescent Fellowship Program. So each one of those program directors is responsible for the training of all of their residents in their program. They are supported by a number of faculty, what we call core faculty, where they actually are paid by QUIA, by the hospital, to teach, both didactic, where it's in a classroom, but also their clinical training on the floor. So those core faculty physicians, so like if you're an emergency medicine resident, the core faculty are all seasoned emergency medicine physicians. In addition, there are other emergency medicine physicians called the attending physicians. So they may not be designated faculty, but they're working in the ED. And generally, every physician here that works, their specialty is in one of those residency programs is a teacher. And so the training of the resident, which also evolves over time. So a brand new resident requires direct supervision. And so when they're on the unit, in the emergency room or up on the critical care units, they have a faculty member, an attending physician that is directly supervising. So if they're going to put in a central line or an IV or any type of procedure they're going to do, you have an experienced physician that is called direct supervision. Then as the resident gains more and more experience and knowledge and is moving through their residency program, they then move into what is called indirect supervision. So not somebody right with eyes on them, but a physician that's generally available on the unit, but is also doing record reviews and looking at the documentation and the care that's being provided by that resident. Eventually, generally when they're approaching their last year of residency, they're very close to be able to go out on their own. And at that point, they can do procedures that they're trained in and they've been signed off in terms of demonstrated competency. They can do things unsupervised at that point. So, if you're a general surgery resident in your 5th year of surgery, there are things you can do completely unsupervised. And so it is the ACGME, and it's not the American College Accreditation Committee for Graduate Medical Education, I think it's called, or commission. They set very strict rules of supervision for the types of things that have to be directly supervised, when they can move to indirect supervision, and all of that information resides in our database. It resides in a information platform we call Workday, and so that any nurse, any physician that is in the emergency department or up on the unit can look and see what level of supervision does this resident require for this particular procedure. Mm-hmm. And so that's where the nurse or the attending physician would go to see, how do I have to supervise this resident?
Mm-hmm. Okay, very interesting. But that's good to know.
Mm-hmm.
It's very good to know. Okay, let's move to another physician, a well-known, well-loved physician that's here in our community. So I received a call. A patient had received a letter that Dr. Manga was no longer going to be practicing at Visalia Medical Clinic, and that her office was going to be sending out other doctors that those patients could move to. But then I had another community member that hasn't received that letter. And so I've heard different communications that Dr. Manga might be keeping certain patients, and other patients would be referred out to other physicians. Do you know what's going on?
I know everything that's going on.
Okay, all right.
Yes.
Okay.
As luck would have it, at our board meeting last night, Dr. Monica Manga, a beloved member of our medical community, the Kauai Health medical staff, she's the immediate past chief of staff. So she served as the chief of staff of our medical staff for 2 years. Dr. Hightower is now our chief of staff, but all of the other medical staff officers were on vacation. And so Dr. Manga sat in for Dr. Hightower last night for the things that the chief of staff has to do with the board. And so I had seen this question, fortunately, and spoke to Dr. Manga directly about it.
Okay.
So yes, Dr. Manga is leaving Visalia Medical Clinic. She said effective August 1st. And she's essentially going into private practice. She has a practice site that is located on Mooney. Is it Boulevard or Avenue or Boulevard?
Mm-hmm.
Yeah, Mooney Boulevard. And so she will be setting up her practice there. So she has been, for the last number of years, has been working half-time at Visalia Medical Clinic, seeing her patients. And the other half-time, she is a contracted, I'll say, medical director provider for Key Medical Group and the Humana Medicare Advantage population. So we have about 14,000 Medicare members that are enrolled in the Humana Medicare Advantage plan. And Kauai Health and Key Medical Group have partnered to be essentially the exclusive provider of those Humana members. And so there are about 400 of those Humana members that have many, many chronic conditions. They are at high risk of hospitalization or illness. And so Dr. Manga is kind of their dedicated physician. She's an internal medicine specialist. So she has a higher degree of training and experience and knowledge to take care of patients with multiple chronic conditions. And so she's the primary physician for those roughly 400 patients. And so she's been doing that for a number of years, again, splitting her practice between that and at VMC. So she will continue to do that Humana piece. But with respect to her private practice, she certainly hopes that every single one of her patients follows her. So the fact that some got a letter and some didn't get a letter may just be timing, but she would love for every single one of her current patients to follow her there. And patients have that absolute right. And if they want to do that, then they inform Visalia Medical Clinic that they want their records released to Dr. Manga, and then she would accept them into her new private practice. She also said that she is open to accepting new patients into her practice. So if you are not currently a patient of Dr. Manga but would like to be, that beginning August 1st, her practice will be open to new patients. Now, the reason that Dr. Manga is not soliciting her patients, but is informing her patients about other physicians is because, technically speaking, her patients belong to Visalia Medical Clinic. They are the provider of record. Dr. Manga has been their employee, but the patient is a patient of VMC. And so by law, Dr. Manga cannot solicit those patients to follow her. And so she, in her letter, I think is providing, that she's leaving and where she's going, but also giving the names of perhaps Dr. Lovelace or Dr. Omololu, other Visalia Medical Clinic primary care physicians. Unfortunately, I've heard that those physicians' practices are full. But they likely have other physicians that I'm not aware of that may have capacity to accept patients. But certainly any patient that is currently a patient of Dr. Manga can absolutely follow her to her new practice, and I know she would welcome them with open arms.
Okay, good to know. So we will share that. And then we were at the EDAC last week, and another member said that they had received a letter that their physician was leaving the area.
Yeah,
and
so Dr. Angela Papp. Dr. Papp and also her husband, Dr. Zoltan or Zoltar? I think it's Zoltan.
Okay.
Zoltar? I think it's Zoltan Mascari. So he's a neurologist that has been practicing a long time at Visalia Medical Clinic. So he and Dr. Papp are married, and they've made a decision to move to Santa Barbara to be closer to their son, who lives in Santa Barbara. And apparently they have a house in Santa Barbara that they have, that they go to often. And they both felt that they're at a point in their lives where this might be the right time to move to Santa Barbara. And I know we're all jealous.
Yeah, sounds good right now.
It does sound good. When I was walking to the studio here, I was walking with a maintenance guy, and we were commenting on it was a little bit cooler today. And he goes, "Yeah, but did you hear what it's going to be next Saturday?" And I said, "Yeah, I saw in the Fresno Bee today it said 108 or 109." He said, "No, it's going to be 122." And I go, "Excuse me? 122? That's like Death
Vegas
Valley.
weather.
That's Death Valley."
Yeah.
So I'm pretty certain he's mistaken, but it is going to be a warm one. So
Yeah. Okay, so if people need, or if you get a letter from your doctor and you need a doctor, you don't know who to call us.
Yeah.
Because we have doctors, Dr. Martinez, who we're trying to help fill his practice.
Right.
And so don't try to trudge through that alone. We are aware of the doctors in the area that may or may not be accepting patients, and we will absolutely help you. You mentioned the heat. We received a chat on the webinar. What is Cahuilla doing? What do we do differently than our normal everyday practice when heat waves are coming like this?
Cross our fingers and our toes and everything. So we're fortunate. So as an acute care hospital, we cannot be blacked out or browned out because of the critical nature of the care that we provide. A number of years ago, we invested in essentially developing a cogeneration plant where we could produce our own electricity. And it's evolved over decades, but today we have a single 3.5 megawatt turbine engine that's located right next to the hospital, that's powered by natural gas, and it runs 24/7. And it produces all of the needed electricity to heat and cool and operate all the machinery and the technology and everything in the acute medical center. We also are hooked continuously to the Southern California Edison grid. So if our turbine should power down for whatever reason, or not being able to produce enough power to cool our facilities to the desired temperature, then we can draw from the grid as well to supplement our cogen energy. We also have 3 diesel-powered generators that in the event that the turbine goes down, these generators kick on within a nanosecond so that we don't lose power in the middle of a surgery. And so those are tested frequently to make certain that they're operating as fully intended. We cut over, we power on them to just make certain that it's seamless and unnoticeable if we have to make that power switch.
So what about healthcare in the community when we have heat waves? I remember there was a story in Vital Signs, our marketing magazine that we send out, about a young man that had a severe heat stroke
Right.
that landed him in our trauma center. So do we see numbers go up when we are experiencing heat waves?
Yeah, I mean, we certainly, try to inform the public, just like the public, Tulare County Public Health Agency, about staying hydrated, accessing our county cooling centers that are available, refraining from, strenuous exercise or sports or things like that during these very intense periods of heat. But yeah, we do see more heat related, illnesses, heat stroke, things of that nature. It saddens me to see the number of young people that have drowned in our rivers, because I know they're going to cool off, but it's ice water. It's, the snow is melting and it's incredibly cold. It's running very, very swift. But I understand the desire to get out of that heat. So we just have to, take precautions, but we're quite equipped and skilled in taking care of heat-related illnesses and conditions.
Okay, so we have a few minutes left, and I know some things were announced in our board meeting last night that you might want to share with the community.
Yeah, so, we had a lot of celebrations. So Susan Fetter, a longtime mammographer at our Kuya Health Imaging and Breast Center over on our West Campus, retired after 39 years last night. So she had her children and her husband there, and Dave Francis, our board member, presented her with a proclamation from the board and flowers, and Susan kind of told her story about when she started here, and it was a tearjerker. But that was a really fun event. And then we celebrated Jenny Faria, who is one of our clinical education instructors, and she was selected as our June World-Class Employee of the Month. She had her 3 boys there, and her friend, she probably had the most in attendance. A lot of her colleagues was there cheering her on. Introduced a couple new directors. Denise, who is our new director of case management. And then also we had Janice Nini, who hails from New Jersey, is our new interim director of our emergency department. And in fact, she attended our emergency department advisory council meeting last week. So folks got to meet her. We passed our budget last night. So by a unanimous vote of the board, they approved about a $900 million operating budget and a $14 million capital budget. Just days before the new fiscal year begins. So that's always a momentous occasion. It will be another very challenging year, without a doubt. I just spent about an hour and a half with our leadership team going over the details of the budget, but the whole, California minimum wage for healthcare workers. Unfortunately, the state being in a huge budget deficit position, the governor has decided now that he's not going to use any of the managed care organization tax to increase Medi-Cal reimbursement rates to doctors or hospitals. He's going to use all of it to help balance the state's budget. So that was very disappointing. Yesterday morning, we had a couple dignitaries visit us here. So Mark Mertz, our Chief Strategy Officer, Dave Francis, one of our board members, and myself met with Carmela Coyle, who is the President and Chief Executive Officer of the California Hospital Association. She joined us in person, as did David Montes, who is the Chief of Staff of U.S. Senator Alex Padilla. So you may remember that when Kamala Harris ran for president and became vice president, Governor Newsom appointed Alex Padilla to serve out her term as one of California's 2 U.S. senators. So Senator Padilla selected Kuya Health out of the 400 plus hospitals in California. He picked us to come visit and learn more about healthcare, the challenges of healthcare, and how federal action could affect our ability to provide high quality, safe, and accessible healthcare services. So we were honored to be selected as that representative for California hospitals. He was very attentive, listened carefully. We talked to him about proposed cuts to Medi-Cal disproportionate share hospital payments, which for us last year was about $22 million. Congress is proposing to cut that in half. So literally to cut Kuya's share of those funds by $11 million, which would have a very detrimental impact to us. There's also a program as a public hospital we participate in called the 340B program that allows us to purchase pharmaceuticals at a significantly discounted cost than we would if we were having to buy them at retail. That cost savings is more than $10 million a year to us. And there's always threats of curbing or cutting that 340B program. And again, that all sits with Congress. So had some really good discussions. We took them both on a tour of our NICU, our cardiac ICCU, and our cardiac intensive care unit. Shannon Cawthon, Melissa Filipponi, Felicia Vaughn did a phenomenal job touring them. It was so exciting. I think they were blown away. You know, they think of us one of those pesky little district hospitals in Podunk, Visalia.
That keep asking for more money.
Yeah, keep asking them for more money and get out of my way. I want to talk to the real hospitals, you know, Kaiser, Cedars, but they were literally blown away by the advanced technology that we have here, just our facilities, the quality of our staff, so talented and dedicated. And Felicia, what a poster child for, I mean, her energy and enthusiasm was infectious. So yeah, we talked about that last night. Oh, yes. And so, so on Monday, bright and early Monday morning, a very significant thing happened. So Sequoia Regional Cancer Center, located on our West Campus, has housed 2 very important aspects of oncology care. Medical oncology, which has been provided by our partners, Dr. Robert Havard, Dr. Chatrath, Dr. Sharma, and soon to be Dr. Gill. Sequoia Oncology Medical Associates is the name of their medical group. And then we have radiation oncology, Dr. David Lee, who leads that program. The radiation oncology part of oncology care has always been a hospital-based outpatient department of Kuya. So owned and operated by Kuya and staffed by physicians that we recruit, radiation oncologists. But with respect to medical oncology, we simply have leased the space and the staff and the equipment to Dr. Havard's group, to SOMA. And so it literally has been a private practice located inside of a Kuya Health facility. And it's increasingly difficult for physicians to survive in private practice. That's why you see many physicians joining now hospital healthcare systems. It was the reason we created our medical foundation that was partnered with VMC for about 7 years. VMC is still a medical group, but now it is part of the Adventist Health System. So it's no longer an independent medical group. And more physicians, again, are having a hard time remaining independent. And so we've been in discussions with Dr. Havard and his colleagues for many, many months. And we eventually arrived at the decision to transform SOMA from a private medical group and practice to a Kuya-owned and operated hospital department. And so SOMA will still remain intact as a medical group, but starting Monday morning, that medical oncology practice, the chemotherapy, that is now a part of the Quia Health system. And we contract exclusively with Dr. Havard and his physicians to provide their physician care. So our partnership is not ending, it's just coming under a different structure and model. But probably the most important thing is now that it's a hospital department, we can access that 340B pricing program. So we now can buy those very, very expensive chemotherapy drugs for pennies on the dollars. And so it will have a very positive financial impact to Quia Health, but also will probably allow us to open up access to a broader population. The state pays oncologists so poorly for providing cancer care services that really no medical oncologist can survive off what the state pays for seeing a Medi-Cal patient. And so SOMA has been understandably very limited in terms of providing access to the Medi-Cal population. So now under Quia's ownership and that ability to access those 340B programs, we'll now be able to extend, I think, greater access to truly state-of-the-art medical and radiation oncology services to that impoverished community that makes up 62% of Tulare County's population.
Fabulous news.
Did I miss anything?
I don't think so.
Okay.
I don't think so. But I did receive a chat that says Apple, iPhones are showing 122 degrees for next Saturday, but Apple is reporting that it's a weather glitch.
Oh,
So
okay.
thank you for, but
Okay,
if
so
something
he saw
happens,
it.
So he was being accurate when he said
Yeah.
that's what's coming. But hopefully it's a glitch, right?
Yes.
But-
And not a superheat dome.
Yes, because we
Yeah.
can't handle that. But I think we're getting ready to end this. We're just a few minutes short, so we want to thank everybody for joining us, and we'll get these in written transcripts and we'll get this posted on our site. But anything else exciting, Gary, that we need to know about?
No, yeah, just thank you again for those that are streaming live with us right now. This does get recorded and kind
posted.
of, yeah. So
And sometimes we pull it apart if you have information that we think we can turn into commercials or Instagram.
Oh, gotcha.
Reels.
Okay. And thank you to many of you that came out again for the new resident mixer. I saw Lori Diamant and obviously Sam and a number of other community engagement folks. So thank you for staying really engaged and involved with Quia Health. It means a lot to us. And again, you have a big impact, a great influence on the decisions we make and what we pursue and choose not to pursue. And we appreciate the feedback, good and bad, because we know we can always get better. Our journey to world class is never ending. And we definitely appreciate your perspective. And I can't wait to do the wayfinding thing again. Is that coming fairly soon?
We're hoping late summer, early fall, we'll be
Okay.
able to bring our wayfinding group
Yeah.
back.
All right.
So,
That'll be fun. All right. Well, thank you all. Have a wonderful weekend. I think it'll be a little bit more tolerable. Soak up any cool you can to build reserves for the following weekend, huh? We can't do that though.
No, we can't. Yeah. Thank you.